Okay. We are ready. Okay. Ladies and gentlemen, now let's proceed to the next lecture. And this one is on thyroid eye disease, also referred to as Graves' disease. Thyroid eye disease is the most common subtype of hyperthyroidism. It's an autoimmune disorder in which IgG antibodies bind to the thyroid stimulating hormone, TSH, thyroid stimulating hormone receptors in the thyroid gland, and stimulate secretion of thyroid hormone. Thyrotoxicosis, which is hyperthyroidism, is a condition involving excessive secretion of thyroid hormone. So this is the mechanism how this disease occurs. Presentation of the patient, usually in the 3rd to 4th decade. Well, listen to the language, usually. Sometimes it can occur in the 5th, can occur in the 2nd, usually in that age group. With weight loss despite good appetite. Increased bowel frequency, sweating, heat intolerance, nervousness, and irritability, weakness, and fatigue, feeling very weak. The weight loss is despite appetite, a good appetite. When someone has good appetite, you expect that they are really hammering the food. But because of hyperthyroidism, there is nervousness, heat intolerance, sweating, and all this weakness and fatigue. What are the clinical signs? External, you have diffuse thyroid enlargement. What do you call it? Ichibukuro? The members call it Ichibukuro. The Tongas call it what?
It's bright. Bright or Jimmy can.
Bright or Jimmy can answer. Ask Jimmy answer that one.
Jimmy, what's this? Or bright? What do you call this in Tonga?
In Tonga. Oh, these are towny Tongas. They don't stay in the village.
Bright is quite knowledgeable.
Oh, he's knowledgeable. Okay. Bright, tell us. What do you call this in Tonga? No idea.
It's coming.
He's coming? You trust him. Okay, let me wait. I learned these things in a lot of languages.
Jimmy or Bright, kindly tell us what this is.
In Tonga.
Doctor. I only know it in English, so I don't know it in Tonga.
Okay, thank you for being sincere. Here you are being promoted. That is the only one who can know in Tonga.
No, that's Jimmy Tonga. Maybe Bright can do justice.
Okay, let's the members go into a teaching or something like that. So there is a growth there which you can see. When they swallow water, it also moves. But there is nervousness, sweating, people are jittery, when the disease is at its peak. Look at the nails. Acropathy. Nails normally are straight nicely, but this one rounded like that. All fingers you check, it's like that. Thyroid disease, acropathy. These are some of the signs you find. This one is usually there. Most of the patients, by the time they are coming, This one, you see it for those that have been with the disease for a long time. This one, they've been with the disease for a long time, pretibial myxedema. And this one, what is this? Ah, that's the one. Cardiovascular signs, you have, because of, they have what you call sinus tachycardia. The heart is pumping faster, but it's pumping normally. They are not in failure. Okay? You have atrial fibrillation and premature ventricular beats. This is what they call high output heart failure, ultimately. Investigations, thyroid function tests. Serum T3, T4, thyroid stimulating hormone, thyroxine binding globulin, TBG, and the thyroid stimulating immunoglobulin. These are the tests which are done. Obviously, in some rural areas, this may be not, it may not be possible to do them. A patient may have to go to a better center within the provincial center. For example, Southern Province, Livingstone General Hospital should be able to handle this. You know, if they can't handle, they may have to come to UTH. Treatment: carbimazole, or propyl, uracil, propranolol. Radioactive iodine can help. Partial thyroidectomy, you reduce the thyroid because it is you leave a bit, you cut a bit. Why are you cutting a bit? It means the effects you are having will be reduced. Risk factors for developing thyroid eye disease. Smoking, those of you who smoke, you are in that category. Me, I don't smoke. The greater the number of cigarettes smoked per day, the higher the risk. Women are 5 times more likely to be affected by thyroid eye disease than men. So this one particularly targets our ladies. There's nothing like, my husband is the one who smokes a lot. But by the time people are reaching this age, all of them are smokers, but blaming each other. That's what happens in these homes.
Bright is now back.
You want to give him the question?
No, for the same, the goiter.
Oh yeah, give him the question.
He has seen the question.
Bright,
how do you call it?
How you call the?
Oh, okay, Daniel. The thyroid in Tonga.
In Tonga.
We call it bonzo.
Say again, ichibonzo.
Bonzo.
Bonzo. Yeah, I'm with you. Is it ichibonzo or bonzo?
Bonzo.
Ah, thank you.
Yeah.
Let me tell you. One day you'll be in Tongaland. An old man will come and will be telling you that, and then you say, "What are you talking about?" You should learn. There's nothing wrong with learning.
There's a message here. I don't know if it's a question.
What is it?
It's just laughing.
It's laughing. Yes. This is a free lesson.
It's a free one.
It's a free one. But very essential as a doctor, very essential as a medical. Because you are going to find an old lady, I have got bonzo. Bonzo. It sounds like bone, but immediately she's talking or he's talking, then you know, oh no, this is Tonga. He's talking about this.
It's important.
Very important to learn languages. That's one of my preoccupation. Wherever what do you say like this? Like operational language, just to operate in the environment. If I'm with a Tonga, you can speak all the Tonga. I may not know everything, but I'll be following what he's talking about. Losses, I had a lot of lousy friends. Until I know, continue talking. I'm hearing now. When they want to say anything, this chap hears. Risk factors for developing thyroid eye disease: smoking, ladies and gentlemen. The greater the number of cigarettes smoked per day, the higher the risk. Women are 5 times more likely to be affected by the thyroid eye disease than men. Pathogenesis of thyroid eye disease: it involves an organ-specific autoimmune reaction in which IgG antibodies produce the following changes: inflammation of extraocular muscles associated with the following changes: cellular infiltration, okay? Increased secretion of glycosaminoglycans, retention of water, muscles enlarge up to 8 times normal size, and muscles may compress optic nerve. Note: subsequent degeneration of the muscle fibers leads to fibrosis of these muscles, leading to restrictive myopathy and diplopia. This is the pathogenesis. As you read at home, you have to understand how the disease starts, how it evolves, what is the mechanism involved. There is an autoimmune reaction to IgG antibodies which produce these changes. We have inflammation of extraocular muscles associated with cellular infiltration, increased secretion of glycosaminoglycans, and retention. There is a lot, the muscles retain the water. So when you do the CT scans, you are going to find the muscles enlarged, because of retention of water. Muscles enlarge. And this muscle enlargement can lead to compression of the optic nerve. Mind you, from the eyeball, muscles, both whatever muscle, superior, inferior, lateral, medial, they end up at the apex of the orbit, and the optic nerve passes through that cartilaginous ring at the apex. So if these muscles on all around get enlarged, they can compress the optic nerve, and compression of the optic nerve leads to disturbances of the vision.
That's a question.
Yes, yes.
Why
Welcome.
are women more likely to suffer from thyroid disease than men?
What did you want here? It's not due to hormones found in red. Some of these things is an observation. It's not that men don't suffer. Everyone suffers, but appears to be more common in women. Sometimes there's no reason why, because all these men also have. They could also be affected, and I've seen some men affected. What is here is just a pathology, and this is cellular infiltration and the lot. That's the pathology, which leads to inflammation in the muscles, enlargement and swelling, leading to compression. Vision ultimately is affected by compression, especially at the apex of the orbit.
Yeah, the question came
From
here.
From here?
This slide for the risk factors.
Oh.
That women.
Oh, okay.
5 times more likely affected.
Oh, why they are 5 times?
than men.
I have no idea, but it's an observation.
So we are now.
There is nothing specifically tagged. In medicine, sometimes you find more common in children, more common in this age group. Not that they've done anything wrong. It's an observation. Inflammatory cellular infiltration lymphocytes, plasma cells, macrophages, all these together leads to retention of the fluid. That's what is happening in those extraocular muscles. And at the apex, that can lead to compression of the optic nerve. Or the optic nerve from the eyeball goes through that into the cranium. So there can be compression, and that will affect the vision of the patient. What clinical features or clinical manifestations? There's a question.
Seems so.
Okay.
Okay. It's just answers that it can be due to hormonal changes.
Yes. Clinical manifestations, thyroid eye disease. No one ringing?
I was checking if it's from.
5 main clinical manifestations, which I think we've talked about even here. Soft tissue involvement, lid retraction, proptosis, optic neuropathy, and restrictive myopathy. So we'll go through those one by one. These are the main clinical features you find in the thyroid eye disease. Soft tissue involvement, you have grittiness in the eyes, photophobia, lacrimation. Grittiness shows like it's dry, the eyes are dry. So you have photophobia and lacrimation, pouring out of tears. Retrobulbar discomfort. Why is it the discomfort? Remember, we're saying the muscles which are behind the eyeball, they swell up in the early stages. They swell up, they enlarge, and they go to compress the optic nerve as it is leaving the orbit going into the cranium. So, retrobulbar discomfort, clinical signs, epibulbar hyperemia, sensitive sign of inflammatory activity. When you look at the eyeball, you will find that there is redness as well. Intense focal hyperemia may outline the insertion of the horizontal recti muscles. You have periorbital swelling caused by edema and infiltration. The orbit, okay? This is caused by edema and infiltration behind the orbital septum, may be associated with chemosis. What is chemosis?
Swelling on the thigh. Probably with
With what? Pus?
yes, pus.
No, there's no pus, your chap. Fluid.
Fluid.
There's no pus. Once you
Okay.
put pus, treatment changes. You change the treatment.
Uh-huh.
Because it means this is bacterial infection, antibiotics. But there's no antibiotic treatment in this disease. Okay. Periorbital swelling caused by edema and infiltration behind the orbital septum may be associated with chemosis and prolapse of the introseptal fat into the iris. Superior limbic keratoconjunctivitis. So no, there is not bacteria. There is no bacterial infection. There is absolutely nothing. Oh, okay. This is the swelling, the redness on the bulbar. You can see this is the cornea here. This is the limbus. So you have some redness here, bulbar area. If you don't know this, you might think he was really punched hard. He's just hiding. But this is a severe case. Thyroid disease, periorbital edema and chemosis. The edema around there. This one is superior limbic keratoconjunctivitis. Here. Inflammation here. And there. I've skipped one. Okay. Treatment now. Any disease, there must be, when patients come, they come with all the hope that some magic will be done. Lubricants for superior limbic keratoconjunctivitis or corneal exposure and dryness can help. Topical anti-inflammatory agents like steroid drops or non-steroidal anti-inflammatory drugs or cyclosporin, these can help. Okay. Head elevation, it means when they are seated, if they are seated like that, they want to, if it's better than just lying because you are going to have puffness of the eyes. This is a crucial stage. Steroid drops, non-steroidal anti-inflammatory drugs, cyclosporin. These are the drugs you can use for treatment. Head elevation simply means you sit. When you sit, the head is elevated, isn't it? Head elevation is not lying in bed. Head elevation with pillows during sleep. Eyelid tapping during sleep. Why are we why do you want to close the eyelids? To avoid exposure keratopathy. Because all these subconjunctiva is swollen. So if they sleep, better you tap that and close the eyes. If you leave them, the person is sleeping but with the eyes open, they have that exposure keratopathy. In order to avoid that, that's why you do eyelid tapping. You tap the upper and lower eyelid, you close the eyelids, then they can sleep nicely. Lid retraction occurs in 50% of patients of Graves' disease. You find the eyes, you are able to see from the limbus, that white above the limbus. That's a sign of eyelid retraction. You see that white patch. I'm sure this one is here. No, this is spirolimbic keratokeratitis. No, what is that? I'm sure we'll find a lid retraction in Panshap.
This one.
Yes, this one. Okay. This one, mild lid retraction, more so in the left eye. I think in the left eye. You can see, you are seeing that white just above. This one is within the normal range, this one. Okay. But when you go to this picture, you can see lid completely retracted because the upper eyelid is supposed to be above or below the limbus. The lower eyelid is supposed to be at the limbus. That's the normal lid position. So once the lid is above the limbus in the upper eyelid, that's lid retraction. Once the lid is below the limbus here, it's lid retraction. Lid retraction occurs in 50% of patients of Graves' disease. Mechanisms of lid retraction is fibrotic contraction of the levator muscle associated with adhesions to overlying orbital tissues, which cause lid retraction worse in down gaze especially. Lid retraction, when they are seated like that, it's there, but in down gaze, when you ask them to look down, the lid normally follows the eye downward. If you've got this lid retraction problem, the lid won't follow the eyeball. So it gets worse on looking down. Okay. Mechanism, there is a fibrosis of the inferior rectus muscle induces lid retraction in up gaze. Yes. By the time you are reaching there, it means they are in an advanced stage of this disease. Secondary overaction of levator, superior recti complex. You have what's that? Humoral induced overreaction of Muller's muscle. What is molars muscle?
It should be on the leads.
Where on the lid? Help him with saying it should be. We want to know exactly where is molars muscle. Help your friend here. No one is able to help him. So it's a difficult question, isn't it? Okay,
No, it's not a difficult question.
we'll leave it for tomorrow. You have to,
There's an answer.
Where is the answer? Someone is offering. Yeah, let me tell you before the person who is offering offers the answer. This is the only time you can make a mistake and get away with it. So you have a chance to try, because after this, when we party, we are in an exam or oral room. There is no room for making a mistake. Here you can make. We shall agree or disagree with you, no problem.
Chima, I wanted to say something. We can proceed.
We can proceed, okay. But this is a very, very common, typical case.
There's, I think, an answer or something.
Which one? Or someone is offering. Okay. Yes, the brave should offer.
But it helps the IPSC to really retract the eyelids. It's invented by the sympathetic nerves.
First,
The question is, where is
the question was what?
where is
Levator.
the molars muscle?
Molars muscle.
It's given the function.
Yes.
But
well,
it's just
not just.
the eyelids. From
Tomorrow's lecture, the first answer will be molars muscle. Homework. There are certain things people take for granted. I know. No, it means you need to read the anatomy.
Okay, can I say upper eyelid?
Yes, upper eyelid. Okay, right. But where? Everyone of you go and read tomorrow the first lecture.
But it's below the tarsal plate.
I like the answers. Let's wait for marking. I'll mark it tomorrow.
That's what I said. It should be below the tarsal plate. It's also not sure.
So fibrosis occurs, fibrosis of all those muscles, obviously, they can't lift.
So yeah,
which means when you look up, if there is fibrosis, it means,
I think the muscular layer, that's an answer from Jonathan.
That's not a good one, because molars muscle is a muscle. So when you say in the muscular, it's the same. We're talking about the muscle. You haven't answered the question. You know that is part of the muscle. This is number 22.
We are on 20.
These are 48.
Yeah, we're on 20.
I think let's move.
We have 2 minutes to be cut.
Be cut?
Yes.
Okay. We'll start.
So I don't know if you can talk about
Clinical signs. Normal lid position should be known. The normal lid position, the upper eyelid margin rests 2 millimeters below the limbus. 2 millimeters. So if the lid margin is above the limbus, that's retraction. You understand? The limbus, the limbus at the superior part. If the upper eyelid, the normal one is it stays 2 millimeters below the limbus. That's the normal position. So any eyelid, when you look at the patient in a straight position like that, if the lid is above the limbus, The upper lid is above the limbus, there is retraction. Okay. Lower eyelid also rests at the limbus. But in some people, it's below, a millimeter or so below.
We can wait for part 2
Okay, no problem.
as we.
No problem.
So join us on part 2.
Upper lid margin rests 2 millimeters below the limbus.